Hello, and welcome to my interesting case for Neuro Grand Rounds. Today, we're going to be talking about a traumatic brain injury case that I previously saw in 2020, a pediatric case in particular. And throughout the case, we'll be talking about moderate to severe traumatic brain injuries and what prognostication means and the importance of ponderance of withdrawing care early or not within these moderate to severe brain injury categories. So let's get started. So the patient that we evaluated was a 16-year-old female with no significant past medical history who came to Sparrow on September 25th, 2020. She was involved in a motor vehicle accident, unfortunately, which she had purposely veered into a group of trees at a very high velocity. She had had a previous psych history before and other suicide attempts. So she, on arrival to the ED and on site per EMS, had a GCS of 3, was hypotensive and tachycardic, was intubated, and was brought up to the PICU pretty quickly following her immediate workup in the ED. She had numerous injuries found, and of those included these seen on imaging here on CT head, CT chest, abdomen, pelvis, and CT C-spine. So pneumothoraces, foramen magnum fracture, and C1 anterior arch fracture of the C-spine. In total, her injuries are listed here. We've got injuries in the lumbar spine and of the first cervical vertebra, and with some ilioaxial instability, occipital fracture, diffuse axonal shear injury, severe traumatic brain injury with loss of consciousness. So pneumothoraces, as mentioned, pulmonary and liver injuries, some hemorrhages, and other lacerations on the skin. So going through her head imaging, we have the CT head here that was completed on the 26th, and it shows tiny intraparenchymal contusion, increased density measuring up to 5 millimeters in the right cerebellum. Some similar findings seen in the mesial and temporal lobes bilaterally, which was suggestive of a tear type injury. An MRI brain imaging that was also obtained on admission the night of the 26th. She was found to have extensive post-traumatic parenchyma contusions, as well as hemorrhage, diffuse axonal injury, and shear injury. That right temporal lobe hematoma that was previously identified on CT imaging. Some flare alterations in the left temporal lobe, likely secondary to trauma and the acceleration change, as well as minimal bilateral subdural fluid collection suggestive of hygroma versus hematoma. So once our patient arrived at the PICU, she had low-grade fevers for quite some time, as well as kind of some running infectious workups that were continuously kind of run on her, as well as some antibiotics with the vancomycin and the cefepime, and infectious disease consults and treatment with clindamycin later. Eventually, these fevers and infections subsided. By the time that PM&R saw her, she was just on the tobramycin nebulizer for this pneumonitis. While she was in the PICU, she had an EEG that was obtained that was suggestive of diffuse neuronal dysfunctions and showed suggestions of a structural lesion. While she was in the PICU, she also had a trach and a G2 placement. By the time the rehab team had come around, it was October 12th, and our exam was conducted at 1:30 at that time, and the patient was no longer on sedation. The patient was not responsive, not following commands, and didn't withdraw to pain. She still had her C-collar in place for the non-operative spinal injuries that she had suffered. Her pupils reacted to light, but there was no blink to threat, and the corneal reflex was absent. She had this alternating decorticate decerebrate positioning of her upper extremities and lower extremities, but with that positioning, she was grossly anti-gravity in strength. Her frontal lobe signs that were positive were grasp and glabellar reflex, but she did not have a pulmotor or snout reflex. She was hyperreflexive, more hyperreflexive in the lower extremities compared to the uppers, and had a positive Babinski bilaterally. She did have clonus with plantar flexion in the bilateral lower extremities, about 20 beats, and we didn't note any spasticity at the time of our examination. So this is kind of where the meat of a lot of the examination came down to for me when I was performing this consultation. When I was pre-charting this patient, it had seemed that this patient had been making improvements throughout the PICU stay, as documented by the GCS score. This GCS score, complicated by the fact that there was some nursing that were completing the examination, and that being then documented in some of the physician's documentation, and then the obvious optimism and hope that some of the responses that they were getting from the patient were hoping to lead to improvements. But I wanted to go through the GCS that I saw in my exam in particular, because I felt that this patient was still unfortunately a GCS of 3 at the time of our examination. And so I've got the GCS pulled up here with the specific scale, and my likely, or what I thought were my evaluations bolded here at the bottom. So as far as the motor approach for a GCS evaluation, the patient did not consistently react to pain, but she did have the occasional decorticate and decerebrate movements that could have been mistaken or interpreted as withdrawing from pain if they were timed right stimulus of pain. And there's also the obvious result that her exam can vary. But at the time of our exam, those were likely not related. During our exam, she did not make any audible noises, and her eyes were sometimes open, did have that pupillary response, but did not have corneal reflex or purposeful following of family members, loved ones, or a provider in the room when we saw her. And so I made sure to clearly document that this patient had a GCS of 3 several days out from her accident, and was not actually having an improvement in her GCS score, despite no longer being on sedation. And this is kind of where I want to tease the point of the lesson that I had learned with this exam, in this case in particular, is that I thought that documenting her GCS of being low at this point was very important, but we'll kind of get to that a little bit later. So, as a result of our evaluation, it's a shocker that we recommended inpatient rehab for this patient, as you might imagine. This patient being 16 years old, we recommended transfer to Mary Free Bed Grand Rapids, as our floor at Sparrow doesn't take care of patients less than 18 years old. So the patient was eventually transferred to Mary Free Bed Grand Rapids on October 15th. And the chart review, as I'm sure a lot of us have done, goes to care everywhere at that point. So on examination for the arrival to Grand Rapids, she was nonverbal, not following commands, but was awake, eyes open, and spontaneously moving her bilateral upper extremities and right lower extremities, similar to what I just described in my examination. Not following commands and not tracking with her eyes, tolerating tube feeds without emesis, and had a strong cough, and her secretions had been improving. So her FIM score was about 18, which is the lowest possible. Essentially, she's dependent. And so this FIM score I want to talk about briefly, which is Functional Independence Measure. It's something that we use on the inpatient rehab floor very commonly. It's used between physical therapists, occupational therapists, speech therapists, and then the overarching bad dogs, the insurance companies. And it describes in numeric form someone's stratification of independence based on different activities that they're able to do, those related to self-care, bowel and bladder, mobility, locomotion, communication, psychosocial interactions, and then cognitive function. And then each of those different categories are broken down into further scores, 7 through 1, 7 through 5 being levels of independence, either complete, modified, or with supervision. And then 4 through 1, those being levels requiring assistance of some sort, tiered through levels of 25%, mid to total assist or dependent. So the course of her IPR stay, I wasn't able to obtain through Care Everywhere, but on day of her discharge from Mary Free Bed, her FIM score had improved from 18 to around 72 based on some of the therapy notes that I was reading, making her about mid to mod to maximum assist based on the different category that she was in. She was more conscious or minimally conscious based on the exit examination. She was min to max assist based on these different categories, UBD, LBD being upper body dressing and lower body dressing. She was able to ambulate with a posterior walker about 600 feet with about 50% assistance from somebody else. And her diet was advanced to a soft and bite size with mildly thickened liquids. And her total IPR stay was 77 days, and she was able to go home before New Year's Eve. So in total, her GCS time frame, just kind of documented throughout the notes here. I hope this gets a little bit picture of her progression. So on the day of the accident, September 25th, her GCS was 3, not improved 22 days after the accident at the time of the consultation that we completed. And then 25 days after the accident, upon her arrival to Mary Free Bed, her GCS was documented as a 6. She was maybe beginning to withdraw from pain per their documentation. And then by the time that she's going home before the new year, 77 days after her accident, her GCS has improved to about 13 to 15 or so. And so the patient has had further outpatient follow-up. So this is a note from January 18th, which she was following up with her PCP. Kind of gives a little bit of social update of where this patient is at currently. So she's living at home with her mother to care for her. She's still going to therapies through origami for speech, occupational and physical therapy. She's able to ambulate with some assist, but uses a wheelchair in certain scenarios in the community. She is able to speak, but only speaks single words and doesn't speak complete sentences, and she follows commands fairly well per that documentation at that time. And so let's kind of zoom out and talk a little bit about TBI categories, and then we're going to talk briefly about a research article that we recently used in our didactics, discussing kind of specifically this case, or where our case is a good example of what was seen in larger pools of data. So here we have the TBI categories. Frequently, the biggest line to differentiate between is probably mild to moderate. And once you get into the moderate severe category, the lines blur a little bit more. But I'll let you read these on your own. But obviously our patient falls into the severe category, having that duration of loss of consciousness greater than 24 hours, the positive imaging findings, and then post-traumatic amnesia, the low GCS score, and all that. So why care about these TBI patients? Obviously, these are extremely prevalent throughout our society in the United States. About 3 million individuals present to the emergency department for TBI each year. Just under 300,000 of those individuals are hospitalized for a TBI. and the moderate to severe category makes up about 12 to 44% of those inpatient acute TBI admission. Interestingly, in that category, 45 to 87% of the deaths involved in this population are associated with withdrawal of care, which is pretty peculiar, and we'll kind of talk about here in a little bit more the implications of that, and especially as a provider. So this article published in Neurology JAMA is titled Recovery of Consciousness and Functional Outcome in Moderate to Severe Traumatic Brain Injury. It was a cohort study, retrospective analysis using this multi-center database, the TBIMS, of which Southeast Michigan and Detroit is included in. It was a 31-year sample from 1989 to 2019. It looked at just over 17,000 patients with TBI ages 16 years and older. Some of the outcome measures utilized were Glasgow and the ED, disability rating scale, and post-traumatic amnesia, as well as the functional independent measure that we were just talking about. So this particular study, their inclusion criteria for moderate to severe TBI was having that injury occur within 72 hours of their presentation to the hospital, as well as GCS of less than 13, post-traumatic amnesia greater than 24 hours, or changes noted on head imaging. Some of the results showed that there was a high prevalence of males involved in the TBI population. Just over half of them had initial loss of consciousness, and 12% of the TBI patients had disordered consciousness at time of admission to rehab. 82% of those unconscious patients recovered consciousness during rehab stay, a pretty high level of patients that recovered consciousness. Some of the predictors of recovering consciousness were related to absence of intrabrachial hemorrhage and then the absence of intracranial mass effect. So the study that we were looking at described disorders of consciousness per their criteria as a coma, continuing vegetative state, or minimally conscious state, specifically quantified as a GCS of less than 6 or not being able to follow commands. And so the results of this study showed that of the 12% of the total population that this study was looking at, the disorders of consciousness patients were more likely to be younger, involved in a higher velocity TBI incident, had intracranial mass effect, IVH or subcortical contusion, and had a longer acute hospitalization. And like we mentioned before, 82% of those patients regained consciousness or the ability to follow commands. Other things that were associated with better functional outcome measures were younger age, male sex, lower velocity TBI fall, the absence of IVH, as we mentioned before, the intracranial mass effect. And then looking at the disorders of consciousness and their FIM scores, our patient kind of falls right in this average range of recovery seen in these disorders of consciousness patients that go to inpatient rehab facilities. So the average found throughout this study was 19 at admission for a FIM score. Our case was 18, and then at discharge, the average FIM score was 71, and our case was 72. So on average, that's an increased FIM score of 43. And that increase in FIM score when compared to the TBI populations without disorders of consciousness was actually higher in the patients that had disorders of consciousness. And then of note, 40% of the disorders of consciousness patients at the time of rehab admission were functionally independent at the time of discharge, which is pretty remarkable to think about. The moderate to severe category, about 40% of them being able to be independent at exit. And then those that didn't have disorders of consciousness, about 80% of them were independent following acute rehab admission. So when we're kind of discussing and thinking about this topic, when disorders of consciousness continues for a long period of time within these moderate to severe TBIs, early life-sustaining therapy is often withdrawn or withheld, and acute medical therapies and interventions are not pursued. And specialized inpatient rehab is not pursued as the thought that there is a poor prognosis associated. And like I had mentioned before, the mortality of this population, this moderate to severe TBI group, is 45 to 87% of that is associated with withdrawal of care. And so it's really worth pondering. And so, with these patients that are having these moderate to severe TBIs and having these disorders of consciousness for a prolonged period of time, it's important to remember that they are likely to recover consciousness in the short term, and almost half, the 40% of them, are likely to regain their functional independence eventually. And so caution is warranted in these early decisions to withdraw or withhold treatment in patients with these TBIs or disorders of consciousness. And I think that's really the key lesson that I learned from following this patient from when I'd previously seen them at their time of consult. I was so adamant about making sure that we were documenting the GCS accordingly, as what I thought was lower than what was being interpreted by others at the time of my exam. And I wanted to make sure that we were giving appropriate prognosis. And I think for me, the lesson to be learned is that moderate to severe TBIs get better. And while it is important to be prudent in examination, it's even more important to remember that in this category, most get better. And so alongside that, researching this topic is very tricky. Once a patient falls into a death category, there's no more data that you can follow once they pass, and so the process of studying that population is very difficult, especially when you compare them to patients that you don't withdraw life of care from. And then obviously with life or death scenarios, false positives and negatives really complicate that situation. And if it was your family member or loved one that was involved in that scenario, you certainly wouldn't want to be on the wrong side of a test result or something that would complicate that scenario. So I hope that you were able to learn something from this. Overall, I really appreciate your time, and I hope to have some merciful interactions with Dr. Andary and Dr. Kaufman here shortly. So I really appreciate your time. Thank you.